Okay, so we're gonna be doing this live surgery, and we've designed all these guides, spent hours and hours working on the case. Now it's time to actually put it in the patient's mouth. And everybody here has worked with surgical guides before, correct? Has anybody not done unguided surgery yet? You haven't?
Not a full arch.
Not a full arch. There's a lot of considerations that go into single units that apply to full arch. And some pictures and examples I've put are from single unit surgery, single arch. So for example, some tips and tricks can be even seen in this first picture. So we've gone over all the different types of multi-unit abutments. So there's straights, 17s, 30s. Some companies have even more drastic, angle changes. You're gonna have these angulation checkers in the angled multi-unit abutments. They function as holders while you're tightening the multi-units into the implant themselves. Because a lot of the times, this surgery, handling these multi-units, is probably the hardest part of doing your first all-on-X procedure. There's a lot of tiny little screws that you're gonna lose. They're gonna be floating next to the isovac, and you're gonna drop multi-units. So the best thing to do is just to prepare for it. You know it's gonna happen. So these things help a lot. They tell you if your timing is on point. They tell you if your angulation is on point, and before you put those temporary cylinders on, you have more so of a confidence that you're in the right area. Because we want to do this in a guided approach every step of the way being planned. Even while starting out, or I should say especially while starting out, you should double check every step of the way. So that brings me to my next step. So surgical guides fitting is very, very important. If your first surgical guide does not fit, everything that indexes on that surgical guide from this point on is not going to fit anymore. Your surgery is no longer guided. So for example, we print out this tooth-borne guide, whether it's a pin guide or it's an implant guide, or you're not even using pins, you're just going straight to platform with what Dr. Ross talked about, the selective extraction technique. If this guide is too tight, there's various things that you can do to make it fit. The first thing I start with doing is we have windows that we cut out in the software. In Blue Sky, you can put little blocks there, and the function of that is not just to make your guides weaker, but you can actually take a look in the windows. You can use a mirror. If you see any gaps anywhere, that means something's not fitting. So even if it takes an extra 15, 20 minutes to get those guides on, it's going to save hours from your surgery if something goes wrong. So if the guide is...
Don't move past that. If you see,
yeah, don't move past it.
I think it's just supposed to be like that.
No.
It needs to be like intimate.
Completely trust your plan. You plan this to be intimate, it has to be intimate. If it's not, you should either adjust the guide or see what's holding it up. Now, adjusting the guide should be probably our last resort in these scenarios, because we are handling a lot of things that are going to be flapped open. There's going to be teeth that are due for removal. And the first thing that we should do is to see if anything like that is getting in the way of our guide seating. So a lot of the times when we're doing these procedures, now, for example, this guide here, there's no flap. If there was a flap, I'm going to make sure that all the tissue from that flap is away from the areas where the guide is attached to the teeth. Now, I think you had a question before where you said your first drill was not going down all the way. So a lot of the times that's happened to me. You're using a fully guided system, correct?
What is a fully guided system?
Do you use keys for your drills, or is it keyless?
It's keyless.
Keyless. Okay, so it has a taper, and then the drill comes down from the taper.
It has a cylinder.
Cylinder, yes. The cylinder, there's a thick cylinder. It tapers down to the drill. You hub it out. It's pretty much fully guided, direct to implant. Yeah. If tissue is in the way of your cylinder going all the way down, that cylinder does not have cutting surfaces on it. It's gonna feel like you're getting held up and you don't know what the heck is holding you up. So a lot of the times you can peek into your guide tube with a mirror, with direct vision, whatnot, if there's anything there like soft tissue, it's gonna feel like, dude, what's going on? I cannot get this thing down there. That's where, you have different options. You have the flat drill, you can take that down. It's, like Dr. Ross said, it's a 5 millimeter diameter cutting kind of sphere, and it'll eliminate anything holding you up. Of course, you have to make sure you're not working on a knife edge ridge, aesthetic zone, anything like that. Pins. So, like it or hate it, we're all gonna end up using pins one day. They're not the easiest thing to work with, but you have to learn how to use them. As much as we would like to think that full arch surgery, we can always rely on selective extraction techniques, we cannot always do that, especially if we're starting with an edentulous patient, or like Dr. Brady said, or Dr. Johnson actually, if you have class 3 mobility, depressible teeth everywhere, we need a segmented model, we need to pin it in. Now, pins are easy to plan, they're not as easy to use. So basically, this guide here is gonna guide where I'm gonna put my pins. So that's pretty straightforward. You snap it onto the teeth, you use the pin drill, you hub it out, you have various holes there, and as you can see, I used around 6 holes. There's a reason for that. Not every hole that you plan for a pin is gonna be able to be utilized for a pin. Because when you're planning these cases, there's teeth, there's cortical bone in areas you don't expect it, there's lamina dura that can deflect, and you're pulling a lot of teeth and you're predicting where you're gonna have bone to hold your guide in place. Now, consider this, you plan this full arch case, it's relying on 3 pins to not only guide your bone reduction, but also your implants and your pickup. Now, say one of those pins is in a canine area and your buccal plate fractured out, and there was infection there, it's soft bone, it's spongy, and the pin cannot possibly stay in there. Now your guide has a pivot, it's gonna rock back and forth, and what do you do from this point? You gotta resort back to analog, you gotta resort back to freehanding everything. Or you bring the patient back, they're gonna be pissed, and you have to start the surgery over again. You have to replan everything. So my solution to that is plan about 3 times more pins than you think you're gonna use, because a lot of the times the pins that you're gonna use, you're still not gonna utilize all the pinholes that you made. Because not only is it a factor that something can be missing from the area that you planned it, but also putting the pins in there that deep up in the vestibule, some patients don't even have the lip flexibility to utilize, those areas. So I overplan and then underdeliver. So this is an example of, we'll get to this soon, but let me go over another aspect about pins. So they're meant to push through the guide and attach to the bone. So it's easier said than done. When you print out your models and you put the guide cylinders in for the pins to go through, it's gonna feel nice and loose. They're gonna have a slight bit of play in there. Now multiply that by 4 or 5 times, that's how many pins you're gonna end up using. You put 1 pin in, it's gonna be nice and smooth. Then you have to find the pinhole for the other pin to slide in. The third one too. Every pin you put in, the guide is gonna get tighter. You're gonna end up using maybe the back end of a elevator to tap it in. You're gonna use any process necessary to get the pins in. Sometimes it's like changing a tire. You don't put them all in at the same time. I mean, let's say this. You don't put them fully in sequentially. You put 1 pin in a little bit, you tap 1 in, you kind of have to play around with it. That's why we like to avoid pins as much as we can. But when you do use them, there is an element of getting used to it.
Anybody have that problem with like tabs too? Like you go drill the hole and you can't find the stupid hole to put your pad in? They're
Haven't used TADs too often, but yeah.
You can't find, like, wait a minute, I just drilled that. Where's
it's a bloody mess after that. So you're looking for these tiny holes under, 2 centimeter gum reduction, and
I know, it's right here. Why won't it?
For sure.
This might sound like a dumb question. Are
Yeah.
pins always used with full flat elevation?
No, not always. Dr. Ross actually.
Gums and you can just pinhole right through them?
You can do right through the gums.
All right.
Yep. But then you have to find the hole under the gums. because you're going to end up laying a flap afterwards. Yeah, it's tough. That brings me to my next topic. Say your pins are good, you're onto your next phase. Now you're using surgical guides that are pinned into bone, and they are reinforced with tubes that you make in Mesh Mixer. This will all make way more sense after we plan this together, because we're going to be designing this case basically from scratch. Say you have all these guides printed out, you go in to put the pins in, you're messing with the pins, you're tapping them a little bit, you finally get it in, but you realize, hey, my posterior right implant guide fractured and now it's loose. You don't want to trust it, but there is a way we can fix it. Now, I'm a cowboy. I like figuring out things on the spot. A lot of the times we're messing with resins. Resins can be fixed with resins, but you have to make sure that it's not so far broken that you cannot fix it. I included this video here. It's a full arch surgery I did on the maxilla. And the back right implant guide, as you can see, do you see the white material around it? So that's core buildup material. The whole guide tube came out. But when guides fracture, the lines are pretty clean. If you line it up and you can fix it and you can make it more solid, I think you can use it pretty confidently. Let's watch the video. So way back over there, those guide tubes, the connection points between the tubes fractured off. After some resin to fix it, you can see the guide tube is nice and steady. All implants went into the place we planned them, all integrated, everything is good. Say you can't do that, I wouldn't rely on a guess. If you fixed it and it looks out of place, take an extra 20 minutes, print out a new guide. It's not a big deal. You have a printer in your office, you have a curing machine, so go take a break. These surgeries are hard, you're gonna be very tired at the end of it. And usually, especially the first few, you're gonna probably plan the whole day for double arch surgery. So, take your time, take a coffee break. It'll be okay. Yeah, single arch start. Drill hangups. When we plan our cases, we try to evaluate patients' lip lines, smile lines, final aesthetics, aesthetic considerations like their expectations, lip folds. Not often do we check how far they can open, and I do recommend checking your patient's maximum opening. So if you don't, you can run into a case like this. Take a look at the guide.
Open big, open big. Open.
The patient can't open. The water? It's there.
Slide your jaw to the left.
Yeah, some saliva will be fine,
Tracy, slide your jaw to the left. Open.
The key is getting that thing out of there now. It's far gone.
Big. Open left.
Okay, some cases can get sweaty, even single units, like I said. So evaluate opening, see if you can actually utilize guided surgery in this approach. We had some questions about root deflections, drill deflections. Whenever we're doing guided, things get in the way. You're planning things around hard surfaces. So teeth are in lamina dura, teeth are composed of enamel, dentin, all of that is way softer than the medullary bone you're going to be placing your implants in. So, for example, if you're placing an implant in a fresh molar extracted socket, you're trying to go slightly mesial to the furcal bone. Please go slowly, flatten the bone, and make sure you have a nice purchase, because if you don't, that sharp pilot drill is going to slide into one of those root areas. Same thing with the narrow ridge. You have a narrow ridge composed of cortical type 1 bone. It's not going to go right down the middle of the ridge unless you have, like crystal sharp drills that you just opened. Even then, it's going to get deflected. You're never sure whether the sharp edge of the drill is contacting right into a purchase where it's going to plunge down. So that's why we like to evaluate first, then see where we can profile and flatten, whether it's with a round burr or with a flat burr. Then we can finally go in, and then we're more sure that the implant's going to go where we want it. Because a lot of the times, those thin areas, we go place guided, if you're rushing especially, you go place 3 implants guided in the anterior for like an overdenture. You go flap it open and your implants are hanging out in the tongue space. Ask me how I know. Yeah, plan well, flatten, and slow down. There's no need to rush. Now here comes the pickup. We're going to be playing with the printed prosthesis that we made for Latoya. We're going to make it look nice and pretty. We're not going to be picking it up here. That's something that you need to handle on your own, but know how to handle. Because after you put the cylinders in, they are guided. So approximately where they're going to be. But it's not a 100%, hey, my cylinder is going to be here. The hole I designed that's 0.5 millimeter wider in diameter than my cylinder is going to slide right over. So even though surgically I think that's a pretty good placement and pretty good planning for the multi-units and the cylinders coming up from it, as you can see, these implants have draw. These have draw. This one is a little bit, maybe 3-4 degrees crooked. So imagining that the holes I planned are going to drop right down onto those temporary cylinders is pretty unrealistic. There's ways around it, and those ways are actually used pretty much every time I do the surgery. So it's always a good day when it drops right on and you're like, hey, good, we're done. I didn't need to pre-trim any cylinders. We can go straight to the lab, make it look nice and shiny, take it to Glazetown, USA. But in a case like this, you have 5 implants, 6 implants, more if you're brave. You can drop them onto the cylinders that have stops. Basically, if you have 2 posteriors and 1 anterior that you can pick up, leave the other implants without temporary cylinders on there. Then if you pick up those in occlusion, you already have your temporary prosthetic picked up where you plan it to be. So after that, you have holes and multi-units without a temporary cylinder on there. You can actually put that prosthetic back on, the picked up one, and you can slide the temporary cylinders through the holes. So it's a kind of a dual-sided approach. So one of them is guided onto your pins or on teeth that you left behind or implants, so whatever you plan. You can get very creative with these things. And then you see which cylinders have draw, pick it up, take it off, and the ones that don't have draw, you reinsert it afterwards and pick those up again. And for example, you can do many pickups. You can take it in and out as many times as you want. You already have your set occlusion.
It's because those temp sliders are long.
They're long, yeah, divergence, yeah.
The bigger your holes have to be to accommodate.
And that's another solution. You can make the holes bigger, but at what cost? You're gonna make the prosthetic weaker. Of course, you can make them bigger. We do that all the time, but at a certain point, when they're so big that you're left with a shell of a resin temporary hybrid, you don't want to break that temporary hybrid and have those implants get loose from the patient biting down on a broken hybrid.
Have you guys done the smart conversion?
No, I haven't. I've heard about it. It's a very nice idea, but we've had a lot of luck with this one. Have you tried the smart conversion? I know. Yeah.
Yeah, and I haven't seen anybody really mirror the digital workflow with that one. It's a cool system, though.
It is a cool system. I like it.
For an analog approach.
With the shell and everything, and you kind of like bite down into it. So, yeah, something to consider. That would be cool to digitize it somehow. Yep. Yeah, and as always, if you're worried, you can print out their segmented mandible and maxilla. You can put the implants in, you can put analogs in, you can simulate the whole surgery. It adds a little bit to the lab bill, but it's way easier doing it on a plastic model than a patient's mouth. I pre-printed my first surgery. I did it all on desktop. I think I posted on my Instagram before, for whoever follows me here.